So I think good evening to everyone who are present here. Uh, I'm Dr. Akash, and I would be your host for next 60 minutes. So today we have all gathered for the program called as Building India Certified Healthcare Workforce, and this initiative has been a kind of exercise that we have been working around for past few years and materialized with the first pilot that we started last year in Satara, Maharashtra with Dwara Health Finance. And the idea was that uh, how we can kind of, build more on it. We can hear the voices from field. We can also hear from the expert, including Dr. Gupta sir and Dr. Nachiket more, understanding the idea and how we can have more partners joining this thing. And before we begin, I think just few things. We will have a Q&A session at the end. So anyone has a questions, they can put it into the chat and we can answer at the end. And we kind of, we'll also kind of open for a discussion at the end. So if we want to have open discussions, we can have in the same phase. So as per the schedule, I think first I would like to invite Dr. S.D. Gupta sir, who is also the Board of Studies chairman for this program. The program that we're launching, it's called as Diploma in Community Health and Digital Health Operations, and also the president of IIHMR Society, to just give us an idea about the value of certification to the healthcare system, and with his vast background leading IHMR, building it from IHMR Jaipur to various institutions, how this has helped across countries and how we pursue the India's future with trained frontline workforce. I think that's the key value which we would like to hear from Gupta sir. Sir, I think over to you.
Thank you, Akash. Let me welcome all the listeners who joined this webinar. Let me also welcome Dr. Moore, Nachiket Moore, Dr. Usha Manjunath, and my other colleagues. Today's webinar is a very important webinar. This is sharing what we have been able to do and what we have in our mind. We all know about the situation of healthcare in India, and for that matter, in all developing countries. That way, we are far better, of course. So, don't want to draw comparisons, but important issue still remains access and availability of healthcare. That's one thing. And how can we reach people with care? Unfortunately, there is a huge workforce shortage in the health sector, and especially at the grassroots level. Though the government efforts have been made to reach people, but I think this will never be sufficient. And if so, it might take longer time. So, what is necessary today in order to improve coverage and access and availability of healthcare? To develop human resources who are skilled and willing to work at the grassroots levels. There may be educated people, of course, in India. We have now no problem of getting educated people, but we like that larger number of people who are living in rural area or distant areas, they come forward and we develop them to provide health care. Today, you all know that the disease burden patterns have changed. The diseases like typhoid, diarrhea, dysentery, they still continue. but the burden has reduced significantly. The deaths have reduced significantly. What has happened is the new diseases, of course, not new diseases, I would say, but there is a shift in the disease trends. So we have diseases like diabetes, hypertension, heart diseases, chronic obstructive pulmonary diseases, uh, cancers, and mental health illnesses, mental disorders. Now, it's not that the people who suffer from the diseases are in the urban areas. They are in the rural areas as well. And these diseases are such, once they occur, you have to continuously provide treatment. First thing is we should be able to prevent. But if we are not able to prevent, then we should be able to provide continuous care once they are there. Where from these people will come? Our health systems cannot do it to that extent to reach people. A person living in a village develops diabetes, not only that he requires diagnosis, of course, but also managing diabetes and also monitoring continuously, and maybe some therapeutic requirements are there. So, who will do all this? Someone has blood pressure. Now, they cannot come to the clinic every time, and so we have to reach them out. First, identify it, and then start with the treatment, and the compliances are ensured, and then they are monitored. Now, for this, we need to really go for an alternative. Prepare people at the grassroots levels with the required levels of skills. Such activities have been done earlier as well. But what was lacking is the standardization of training. So, standardized training to these grassroots level functionaries, which we plan to do. Number one, standardized training. And then recognize them that they are certified, they have the requisite skills of helping people in managing the diseases. And then their acceptability increases. So the program that we are talking about, this is an education program, diploma in community health and digital health. So one is training, building skills, and standardized. And this is in line with the National Skill Development Council and Health Skill Development Council. But the second important thing is how can we develop a referral system? So digital technologies that have come in. So this diploma in community health and digital health operations will enable these skilled workers for easy and faster referral. And maybe things like telemedicine and telediagnostics. And in the modern era, we have tried all this. The diabetes management or hypertension management or mental illnesses can be diagnosed using digital technologies. So we have a larger aim to reach people, to address new issues or the major issues, I would say the diseases like diabetes, hypertension, or mental illnesses, and harnessing digital technologies in easy access and referrals. And this person whom we are talking about, we have successfully tried this model in Maharashtra with the help of Dr. Nachiket. And, uh, Dwara Foundation. And we see we have been able to make a difference, and we now plan to expand it further. So this webinar will aim at sharing our experiences and also what future plans that we have. So this will be talked about. So I see it has a very promising future. The need of the hour to have people who are skilled in diagnosis and disease management, and not only that diagnosis and disease management, prevention of diseases is very, very important. It's better not to have a disease, but if you have, then one should be there to diagnose and manage it. So this person will be trained in prevention and health promotion as well. I also feel we should also help them to be part of the disaster management at the local community labs. I think this is the part that we need to also look at, that they are. And another important thing that I look at, we are not having real time data with us. And if we develop some mechanism to connect with our data servers, and they are able to feed data online in real time, I think that will be something very transformative and revolutionary in planning process, in monitoring process, in solving issues that will help in a big way. So let me welcome you all to this important webinar, and my colleague Akash and our friend uh, Dr. Moore will share more on the subject that we have chosen today, building new workforce through standardized training and certification, and using digital technologies to reach out people with the chronic diseases, especially like diabetes, hypertension, or heart disease or mental illnesses that will help you. Okay, thank you very much for joining us. Over to Akash.
Thank you, sir. I think that was great insight to start with. I think now I will invite Dr. Nachiket Moore. I think he needs no introduction, but he has worked across financial inclusion, public health, and healthcare system design, has shaped the policy thinking in India for 2 decades, and he has also served across boards of Reserve Bank of India, Bill and Melinda Gates Foundation, and currently he is also an advisor and a member of Board of Studies of IIHMR Bangalore for the Diploma in Community Health and Digital Health Operations Program. I think the focus from Dr. Morse is like, what is the global learning in certifying the frontline workers, how it has benefited, and how India can learn from that, and how we should also kind of, think of engaging more in terms of certifying the frontline workers to strengthen the healthcare system. Over to you, sir. Thank you.
Dr. Gupta, Dr. Manjunath, and Dr. Prabhune, Bindu Anand, and all the participants in this important discussion. I'm very pleased to be here and to join the IIHMR team in welcoming you all to this important discussion. Dr. Gupta has already given you a detailed background, and I'm eager that we move on to the next phase of the discussion. I'll just add a few things that Dr. Prabhune asked me to speak on. Several things have changed in our healthcare landscape. One thing Dr. Gupta pointed out is that the disease burden has, I wouldn't say, as he said earlier, that the older diseases have completely gone away, but a whole range of new diseases. Even the health and wellness centers of the government of India, unlike the earlier sub-center PHC focus, which was on MNCH, now have 12 conditions they need to address. In reality, if you go deeper, there are over 150 conditions that are treatable, at least identifiable in primary care situations. We also have a mature, it started during COVID, but now has gradually matured, a whole telemedicine guideline that allows doctors situated in remote areas, in remote locations, to collaborate with frontline workers to actually do, to offer prescriptions, to begin treatment and to manage treatment. The challenge has been that despite being a pioneer in the community health worker space, we have not fully utilized the potential of this very powerful workforce to convert these important changes in the disease burden, in the regulation, into something that's actually deliverable and delivered on the ground. And to my mind, if I look around the world, countries that have really addressed this issue in a fundamental manner, countries in our neighborhood like Thailand, countries a little bit further away from us like Alaska, for decades now, they have used the power of the community health worker to deploy very advanced disease treatment in collaboration with doctors. There is no proposal here to transfer prescribing capability to community health workers. And the big step that they have taken, which is the missing step that now IIHMR is taking, is the process of certifying the individual. Training, actually, many workers already to some degree have, but they are not certified. There are also some legal skills. For example, phlebotomy is not a skill that can be taught, but you cannot start drawing venous blood unless you are certified formally by a government recognized process, because otherwise you are breaking the law. And you are subjecting both yourself and your patient to harm. Now you might say, why is phlebotomy important? Well, the reality is when I go to a family's home in a rural, remote location where diagnostic labs are hard to get, where any case the patient is somewhat reluctant because they are busy with 100 other things, they're running a shop, they've got to go to the farm. You tell them, well, why don't you come back to me with a fasting blood sugar? Well, the person is not going to show up for another 6 months, by which time the disease has progressed quite dramatically. Now, there are two directions one could have gone. Like the same issues come up with the health and wellness centers. We have 12 conditions. We can imagine 12 specialized workers. One doing mental health, one doing diabetes, one doing maternal child health, one doing, infectious disease. You can already see that in a village of 3,000, 4,000 people, having 12 health workers deployed is just an infeasible idea. The approach that many countries have taken, and the approach that IIHMR has taken, is to go in the opposite direction, is to find a way in which an individual worker can be sufficiently trained, equipped with technology, equipped with protocols, partnered with the appropriate digital connections to doctors and diagnostics, that they can actually offer services to patients, for a full range of diseases. And I'm hoping you will get to hear a little bit from Dwara. They have actually converted this abstract idea in collaboration with IIHMR into a field-based successful operation, which is legally compliant, complies with all possible laws of prescription, diagnosis, blood draw, all of it, but now is transforming health outcomes for people in the field. I recently came across another organization in Kolkata called the Foundation for Innovation in Health. They're also, moving somewhat in a similar direction, though I would say the IIHMR program is the most complete design that I have seen. So I'm really excited to see where this program goes. I would urge anybody here from foundations, NGOs that are interested in health to really join hands here and to see how we can, instead of simply increasing a whole lot of people who are somewhat half trained for field work, can we build a certified workforce? Dr. Gupta pointed this out so nicely, that there must be standardized training and recognition of that training in a formal way, because that will then transform career paths, that will then allow people to claim academic credits and build both capability to deploy in the field as well as to build their own careers. I'm very pleased to be here, and I look forward to the further discussion today. Thank you.
Thank you, sir. I think that really added a value to the discussion. I think what we'll do next as per the agenda is that we'll have a brief about IIHMR Bangalore, and then Dr. Usha would be presenting about the program, like how we have designed it, what is the idea. And I think then Dr. Bindu from Dwara will take it for understanding the field experiences. So I can quickly share my screen and so I think sorry, yeah. So IIHMR Bangalore carries a 20 years legacy, and we are in Bangalore since 2004. Uh, it works with a vision and mission to kind of lead the management education and being in multidisciplinary areas. We have been successfully running the MBA level programs, the PGDM in hospital health management, PGDM in data science, and now we are also studying the PGDM in farm management. These are technically the postgraduate programs, but to a larger extent, there was a lot of discussion around skilling, and we have been able to kind of get the NAC A accreditation, which allowed us to enter into the field of primary healthcare. And there has been a lot of work that we have been doing in terms of research and training for the frontline workers and in terms of impact assessment, social assessments. Also, we also have a NABET accreditation for NQAS assessment and NABH assessment of hospitals. So I think that overall brings a strong case wherein the primary healthcare becomes one of the focus. And Admire Center has a recent addition where we have a skilling hub, which focuses mostly on aiding technology for skilling of the people in healthcare. And that was where this DCHDHO program kind of fits with the IHMR's larger vision and mission. This is kind of, the journey over last 20 years where we kind of worked with AICTE approvals, NABET accreditations. We also have few programs that are focused on health, IT, digital health. There is also a full-fledged 2 years PGDM program, AI data science, focused on bringing healthcare graduates into the domain knowledge into the AI side. And now the pharma management also has been initiated for this year. These are the accreditations which kind of allows us to grant diploma programs. So legally, we are also kind of with the HSC, that is the Health Sector Skilling Council. So the diploma carries equivalency and weight for whoever gets this as a frontline worker. So that will have focus for further education or in terms of their career growth. That will not have a kind of any legal issues. These areas is where IHMR Bangalore has extensively worked. Recently, our team is in 4 states of West Bengal, Assam, and even Andaman Nicobar Islands for the LASI survey, that is the longitudinal aging survey. Last year, we were part of the NFHS 4, sorry, NFHS 5 for the government of India, and we have been working with NHSRC, we're working with UNICEF agencies. Also, we've been partnering with a few other international agencies where we are working across the research spectrum in terms of implementation research, policy research, health system strengthening. The NHRC has been one of the bigger uh, funders, and also we are supporting Andhra Pradesh government and Karnataka government in terms of ABDM with our DHE, the Digital Health Exemplar Study. So that's the scope of areas that we have been working around, and these are the partners. We are FCRA compliant. We are also have all the details registered for the CSR1 part of the Darpan portal, and ATG compliant for anything that relates to the regulatory aspects. Um, yeah, these are some of the partners. We have been extensively working with HCL Foundation for their Uday and Samuday program. John Hopkins University, we recently completed a study called Digital Health Exemplar, which is a 5 country study, including India, Ghana, Rwanda, Brazil, and Finland. Uh, Cornell, we have partnered for the clinical trial, community-based clinical trials running in Andhra Pradesh. We are also NABH kind of received an award for building an AI-based sentiment analysis tool. We also received a grant from EMITS for the CSR for building a digital diary for autism spectrum care. That's a thing largely portfolio from various funders, including national, international, CSR, and even the government partners for us. These are the domains that we've been working around to a larger extent: public health research, nutrition, and healthcare, also one of our area, digital health. Admire Center has been promoting a lot: healthcare quality, health insurance, and pharmaceutical management. We also offer a lot of training programs that are executive programs, certificate programs. The uh, professional practice sessions and MDP programs. These are kind of designed based on industry requirements. We also have industry faculty being part of these programs and kind of enhancing the output of learning. This is some of the brochures that we have. It's just for the information. Like they're currently running for last 1 year. We have been having multiple cohorts running for the digital health and smart system. This is the third cohort we're starting, and health advancing nutrition and excellence in clinical nutrition. This again third cohort running. So Gen AI for doctors, we have second cohort which will start in this May. So there are some of the programs that we are currently running in repetitive mode. NABED accreditation allows for the part of QCI. It helps us to kind of undertake the consultancy work for the NABED accreditation of hospitals. Yeah, I think we are also recognized under the Gunvatta Pashala campaign of the NABH. At my center, I think this is one of the newest addition, and under which we have been able to propose the DCHDHO program. It has, I think, 4 hubs, what we call R&D skilling digital health lab, which essentially is one of the very first kinds in India, which works on kind of using domain-based knowledge to build digital health tools for healthcare, including LLMs and all those new AI gen aspect. The center has been kind of, generating revenue for long, and we have a list of published papers. We also have 1 patent, and we are also pioneering into healthcare interoperability for long. This is the DHE program that we have been successfully completed. Few papers are in pipeline. They will soon come and can will share across the spectrum. This is, I think, the diploma and clinical program which we are kind of today discussing, and it has been really a wonderful 1 year with Dwara's Neem Sakhi team, where we really able to build a very comprehensive program and pilot it to understand and kind of work on the nitty-gritties. This is the fund that we project that we're doing under the EMIT CSR of building the digital diary. This is the very first time that we are investing into a UX research for Indian diaspora, because a lot of times it's the Western market that dictates the term of how UX should look for a healthcare. But this is the thing we are revolutionizing the aspect of building for India, building it in India, that too from a digital health perspective. And it's also a multimodal where there's an AI built in with audio, images, and all other perspectives bringing in. This is one more area where we're targeting the frontline, but this time it's with the MBBS doctors. So we're working with Foundation of Excellence to place a cohort of 25 fellows into rural hospitals and kind of improve the accessibility to rural population through this program. It's our perspective is that how to build a kind of sound fellowship which would be attractive both for hospitals and for the fresh MBS graduates to be part of this kind of program. So that's, I think, some of our efforts. In terms of AI portfolio, we have been having building models for diabetic retinopathy. This is the models we have tested. We are also working on diabetic foot ulcer, and with lepra, we have built entire leprosy stack that's there for kind of end-to-end management of leprosy from diagnosis detection till the rehabilitation part. We have been working on medication kind of detection also. We have done this with Karnataka government, and ECG is where we're also working with Heart Health India Foundation to kind of digitalize the hard copies and make it accessible across the spectrum using interoperability. So that's some area that we're working around. This is our partners, I think. Just to kind of have idea about the scope and the possibility of partnership with IIHMR Bangalore. I think with this, I would hand it over to Dr. Usha Manjunath, the director of IIHMR Bangalore. She has 30 plus years of experience into healthcare strengthening and largely have been working around quality of healthcare and also strengthening of health systems. We have also completed a study called as understanding the ASHA workers requirements and how there is a state of the frontline workers in India, which also kind of had a very learning experience for us on designing the DCHDHO program. And I think over to you, ma'am, for ma'am, your mic is muted.
Thank you, Akash. And thank you very much for introducing IIHMR. And I thank and welcome, all the participants. And thank you to Dr. Nachiket Moore and Dr. S.T. Gupta, who has been, standing by us to really motivate us to do different things. And for this particular program, I also am very thankful to Dwara team and Bindu Anand, who will be talking a little later about the program. So I will be discussing a little bit in detail about this program. So I will share my slides and and talk about how this whole program is designed and how we have come up with it. So already the stage is set as to what this is all about. Just to kind of start off, I mean, really looking at 1 million ASHA workers in India, but then there are about 5 lakh community level health workers in the sector of non-governmental and civil society organizations. And that is the number that we are really looking at, where we kind of understood, and people in Dr. Moore and Dr. Gupta sir has already said that it is very important to look at their standardization of skills, and eventually the community will be able to get the quality of care, which is very, very critical. And that will be the goal for this whole program that we are discussing. So, I will just briefly look at what the research has taught us, what are the design principles of this particular program, research to the curriculum, how we have gone about it, and then where we are today. The DCHDHO is no longer a concept seeking validation. We are already having a program which is validated, which has shown results, which in the later part, Bindu will be talking about. And what do we think we would like to really go from here in a 3-year time that we want to envision? This is a particular, photo that you see on the right is, the media where they had some of our workers who are trained were, participating in a campaign and a camp there. So this diploma in community health and digital health operations is 11-month, 4-term competency-based, that certifies India's frontline healthcare workforce, combining clinical skills, digital health literacy, and community engagement and AI-enabled clinical decision support. And this is all. The program is aligned with HSSC, NSDC for the standards. So it is a portable, nationally recognized credential that travels with workers across the employer. So they could, change jobs, they could change places, but then it will definitely be with them. Clinical competence is also backed by digital tools. So a worker in a village has the same decision support in a city, a hospital, in a city hospital that he can really have access to. A pathway from informal, currently, are they trained? Yes, they are trained. They are working, but it's more at a informal training and skills that they have got. So this formalization and standardization and certification will really be moving the healthcare workers from invisible service to recognized profession. What are we really talking about when we see this particular program? In terms of how we are seeing this one program and the 3 pathways that they can get, and then the 3 pathways that could be out. So this 11-month diploma will train them. So at the entry level, let us say, for example, there are already existing frontline workers who are experienced and uncertified, or they could be fresh 12th pass people who will be seeking a healthcare career, or they could be micro entrepreneur in the rural sector and wanting to build a livelihood. So this 11-month program has 4 terms. In that, 2 would be the community health facilitator. The next 3 months will be on the digital health technician, along with a co-pilot integrated from term 2 onwards. And then, in terms of the multi-purpose healthcare worker, we will be really talking a little bit more in detail further. And then finally, the community health leader. So what are the pathways outside? So one is the certified community health professional. It could be wage uplift, career mobility, recognition, and very, very importantly, quality of care to the community. Formal healthcare employment, hospitals, diagnostic labs, and home care probably could also be a possible, avenues for them. The certified home care practice, independent livelihood with clinical linkages that they would have. So, where did this all come about? Akash already has said, as we do research, I've just taken some recent ones as we really looked at. We worked on the ASHA workload case study, and this was, we worked in the state of Karnataka, and we really understood that frontline workers carry an undifferentiated burden: counseling, screening, documentation, follow-up, referral coordination, and stretched thin across hundreds of households. But then how is this going to shape the DCDHO? So we looked at competency-based progression. So every new skill must replace something less valuable and not add to the load, as that happens in the case of ASHAs. Whereas in 2024, we have worked across the community health officers at the health and wellness center, now called as IIHMR Arogya Mandars, and 15 districts in the states of Karnataka, Madhya Pradesh, as well as Rajasthan. And we learned that workers carry not only the physical load but also the emotional load that they would be really looking at: uncertainty, anxiety about clinical decisions, and professional isolation. So so that way we built into it these 4-term leadership part and the peer network module, where they could also, if they are conducting a camp, they could probably bring in their peers, and also the co-pilot for clinical decision support in the field, which would be accessible to them, as they work and learn and work with the people. The other is the manpower allocation study with machine learning mode with primary healthcare staffing. We learned that frontline workers' value depends on clean integration into larger primary care system around them and the referral part of it. And so if we really want to take it further, so we need to have referral protocol standardized, structured documentation, and also train them on the ABHA interoperability, as well as how to you really use, and even ABHA registrations that they can help with. So it is the 3 principles that really shaped DCHDHO is that it is not just the course only. So it is the concept of course to career. And I think many of the CSR, or whenever people are funding these kinds of programs, definitely they would want sustainability, they would want entrepreneurship linkages to micro entrepreneurs, and the ongoing co-pilot access to every graduate would be also there in this particular program. So this is, why does it matter? A credential without a pathway to work is a piece of paper, and this program is designed to take a learner from enrollment to sustained livelihood. And it's not bolted on, and it's kind of interesting to really see that we are not going to be continuously this win, but they can be independently doing it. So the AI co-pilot built at Admire is a part of academic design from term 2 onwards, and a frontline worker in a village has the same clinical decision support as a worker in a city hospital. So the technology that arrives after the training ends rarely, kind of, if I put the technology after they have been trained, or an app given to them, maybe the less likely that they will use. But this is integrated into the curriculum itself, which makes how the worker thinks, not an app that she opens occasionally or rarely uses later. So I think that's the very, very important pitch that we have for making this program very different. The other is we are not creating parallel systems. So we have, going to really look at the alignment with HSSC standards. Mapping has been done, and Akash will be talking a little bit more very soon with the qualification packs of job roles of GDA, MLT, physiotherapist, and so on. And these skills that the system does not recognize do not change a worker's life. HSSC alignment is what makes the DCDHO a credential India's healthcare sector that can actually absorb. So I think this would be a very important one. Very quickly moving over to design principles from research to curriculum. So the term 1, which is 2 months, will be really looking at very importantly basic clinical skills, and digital literacy and digital comfort to really use it. And how does this really benefit? So you can see on the right, confidently take and record vital signs, create an Aadhaar digital ID for community member, identify household NCD risk, conduct a structured conversation, and so on. So we have looked at three very important stakeholders. Community, yes, they get a digital health records through the ABBA PHR when it is actually rolled out. Then NCD awareness reaches this doorstep, and including villages where formal systems have never reached. And the civil society organization will have a trained basic competent worker who can enroll community members into formal health systems within 2 months of joining. And the frontline worker, obviously it's a foundational confidence, a recognized role in his or her community, and for the formal credential of her career that moves on. So, yes, in terms of really moving ahead to see the next 3 months is where we are looking at the digital health technician, as we are all aware, and we are also very much point of care devices, a lot of various aspects that are used at the at the care level. So these are very important, whether it is using for conduct a complete non-invasive NCD screening, maintain a structured electronic health record, or doctor's telemedicine consultation in a village setting, which can be very, very meaningful and technically very good, counseling of patients on medication and lifestyle. So again, we have mapped the community level advantages, how they will really have, whether it is in the quality of care, the follow-up, the telemedicine really becomes a real service, not a phone number or a poster that we really see. And the civil society organization, we kind of talked about prevention and promotion have to be the most important one. So, screening them early, getting to know the level of the burden and how to really keep them active. So these are some of the very important part of the screening camps, and the frontline workers could have mid-level clinical competence, first meaningful integration of technology into daily work, and visible elevation in community standing. The last 3 months would be in terms of the third term, I'm sorry, in terms of the digital multi-purpose health worker, in terms of, drawing the blood, sample collection, handling, transport, conduct AI-assisted ECG, identify referral worthy findings, recognize and document clinical red flags using protocolized criteria. Again, we have mapped at different levels how this is going to be there. And this, I think, is the most important, that the community will be able to get the benefit of the latest, testing and digital testing mechanisms, where they don't have to travel a long ways, but then that will be further, for in terms of referral pathways are defined, and therefore the frontline workers can work with confidence and recognize as someone who can do, not just counsel. And so therefore this we see could be a wage uplift potential may begin at this stage. Moving further onto the community health leader, doing campaigns, taking care of panel of patients across the formal health system, managing referral ones, supervise junior workers and mentoring peers become a reality. So our coursework in the last term is for the building the community health leader skills for them. And this would be in terms of community, a trusted person is there with them. And then it's very important that the cadre of community health workers can run these programs, supervise, and make it very, represent the formal health forums, and also interact with the government systems. And then this is where we see that the career mobility into supervisory roles are possible, and recognition as a leader pathway opens to formal employment, entrepreneurship, or both. So as we saw, how these 4 terms lead to improved care. So we saw 4 levels of the terms. Term 1 is community health leader, digital health technician, multi-purpose health worker, community health leader. And then there are pathways that we see that at every level, the community, civil society organization, and frontline workers really look at. So this, I think, will be the most important in terms of the scaled cadre, I mean, the skill cadre that scales delivery. So therefore, since this is all very cleanly laid out, it is possible to really look at it. And at the community, it is a quality care at doorstep. And for the frontline worker, it's a career, credential, and livelihood. So overall goal, improved primary care at the last mile. So where are we today and how we have done is no longer a concept seeking validation. So we have already done this work in the district of Satara of Maharashtra, Vadodara, and so we have trained 11 frontline workers in active training. The current cohort is undergoing the term 4, and it will be completed in July 2026. And this 11 Neem Saki workers are currently in this particular program, have already done, and Bindu will be highlighting a lot more of this. What the field evidence tells us is on the vocabulary acquisition, biological reference ranges, red flag, recognition, then blood sample safe blood sample collection, and building the community trust that has been documented and shared with the Board of Studies. So we have already started seeing early results and very positive results on this. And so we think this is going to be the most important part that we see. And then when the field outcomes become from the cohort 1 at Vadodara, what we really look at the observable shifts is that from cold to, so clinical vocabulary, just an example, from cold to upper respiratory infection. So, people are now, the workers are now describe patient presentations in terms a doctor or a telemedicine consultant can act on, reducing communication friction at the referral interface. Biological reference ranges, knowing when a number warrants action. Workers can now interpret blood pressure, blood glucose, BMI, oxygen saturation against normal ranges and act accordingly. And a reading is no longer just a number recorded in the EHR. It is a clinical decision input that they are able to really make, meaningful decisions based on that. So in terms of red flag recognition, protocolized escalation in the field, workers can now apply structured red flag criteria for chest pain, severe headache, breathlessness, and obstetric emergencies, escalating to telemedicine consultation or hospital refer within minutes and not hours. The safe blood sample collection and community trust, when a worker can do, I think this is the pitch, when a worker can do, his or her standing changes. That means, so therefore what we have seen and ensured in this program is that they actually perform. So each worker in this program have performed 20 plus supervised venous blood draws. Community members who previously traveled to district hospital for blood tests can now trust the worker to collect samples locally. So these have been, very, very important as we go ahead. Now to inform the curriculum refinements going into cohort 2, I think we've been, very specific outcomes have really shown us that our program is quite well defined and delivered. So beyond the pilot, what's already lined up, there are, Dwara Health Finance has already contracted us for the second cohort with 15 workers, building on the Vadodara experience with curriculum refinements applied based on cohort 1 field observations. And further, Wipro Foundation has already contracted us for the year 2 cohort with 30 workers across 2 locations, Mumbai and Mysore, as part of Wipro Foundation's healthcare skilling commitment. So this will be in Maharashtra and Karnataka. And the project potential are in discussion with 30 workers in Kishanganj in Bihar. Discussions are quite advanced and partnership architecture are under finalization. So government of Arunachal Pradesh has shown interest, conversations are in, EOI review has been happening. So they are looking at ASHA worker certification as a possibility, expression of interest under review with the principal secretary for the certification of ASHA workers across the state of Arunachal Pradesh. So combined with these pipelines, it represents about 75 plus additional certified health workers in these 4 states. So this is how we are envisioning for the next 3 years. So now we have finished almost with 11 workers, and that's cumulatively we go to the next year about 100 added. Then we are looking at the year 2 with 150 added, and in the year 3, 250. So that would be 500 plus people that we are really looking at it. So it's a catalytic CSR partnership. So this, we seek partnerships, building the institutional infrastructure that allows DCHDHO to continue and replicate beyond the funded period that we have right now. So that's about the program details, and thank you all. And over to Bindu, and maybe over to Akash for the next part of the presentation and discussions.
Yeah, thank you, ma'am. I think this is the time when we are waiting for. So I'll invite Bindu ma'am to just have a intro about the Dwara NEEN program and how the CHDHO has been part of the larger scaling perspective, and what is their experience with the program. And I think over to you, ma'am.
Thank you, Dr. Akash. It's really been a pleasure to be part of the inaugural batch of this diploma. You will actually hear later from one of our health workers who's been through this program, but I wanted to take a few minutes really to share how this makes sense as a primary healthcare provider, both from a sustainability, revenue perspective, but also importantly, the patient satisfaction perspective. So when we were first, let me put this in full screen. Yeah. So when we were first thinking about how to structure the Dwara Care team, and this is all pretty new, the last 2 to 3 years, we looked at several programs that had been running for many years, where the health worker was at the front line. And really we saw 2 popular formats. One where the health worker is a volunteer, so no real formal compensation, intermittent work, ever-changing sort of responsibilities. And the other where the health worker is really some sort of entrepreneur, which really means that they would earn based on what they sell. So the emphasis was a lot more on product selling, etc. Both didn't sit quite right with us because we wanted healthcare, our health workers, not to be so much free agents, but to be part of a formal care team that includes physicians, specialists, and so on. So they had to sort of fit within that perspective. They had to follow very specific protocols, both for screening, care, and referral. And importantly, be accountable for outcomes of defined cohorts of users/patients who were in fact paying us on a monthly basis for the service, right? So it had a very sort of different implication. And to us, then it followed quite logically that these workers had to be full-time, formal workers with formal training, formal certification, much like any other member of the care team, right? So that was sort of a bit of a starting point for us. Around the same time, Nachiket pointed us to the Alaska model that he briefly talked about, where the community health aid, the CHA is a frontline in their context, performs a whole range of functions: emergency care, MCH, chronic disease management, behavioral health, clinical procedures like suturing, maintaining IV, basic lab tests, etc. This was by far a much more ambitious both vision as well as execution. And of course, they've been doing it for many decades compared to anything else that we had seen or heard of. And this really felt to us like the right direction for a program like ours, aiming to develop a commercially viable primary care model for rural India. As Dr. Manjunath very rightly said, at the end of the day, if you want the user or the patient to sort of recognize, value, pay for your service, there has to be a real demonstration of capability. When we looked at what was out there, however, there was really no formal training or certification available for health workers. In fact, to get a phlebotomy capability, you need a minimum of a 6-month classroom session, which is simply not practical, right, in contexts like ours. So this is when we turned to IIHMR and found a lot of alignment with them. And of course, they have wonderful experience, as was shared already, in certification skilling, and we decided to work on this together. As the kind of first batch, we had a bunch of practical considerations that I would say the IIHMR team has been very kind to incorporate into the design. For one, all our workers, live in Satara. They have to be trained where they are, right? We could not bring them to Bangalore for classroom sessions, etc. Second, as the employer, I cannot afford for them to be sitting in classrooms for weeks at a time. Many of them learn on the field, are actively sort of working. So the training had to be, as much as possible, a combination of field, some classroom, of course, and a lot of self-learning delivered by our learning management type solution. The classroom sessions, in terms of what they focused on, and Dr. Manjunath covered this wonderfully, we were very clear as the, in some sense, the receiver organization that we wanted a lot of focus on technical skills, phlebotomy, suturing, handling a portable ECG machine, doing imaging of oral lesions, how to do motivational interviewing for patients who are struggling with adherence issues, keeping patient health record updated after every visit, recognizing red flags, etc. Right? So the focus had to be very clearly on that. And the request was to keep theory, medical terminology, which often just because of the language becomes a huge barrier. So keep that to the absolute minimum. Again, keeping in mind that who we are trying to skill and certify is really a health technician, not sort of a mini physician. So it's a different cadre, different requirement. And I think it was important to be rooted. And to IIHMR's credit, I think they took all of this feedback fully on board, and what was delivered and what's being refined now very much speaks to many of these issues. Importantly, we want health workers, both ours as well as others in the industry, to be prepared to benefit, I think, from a whole wave of diagnostic innovations that are in the pipeline, thanks to AI, thanks to miniaturization. I think there's going to be a lot of options in terms of diagnostics. They are all very, very far away from being DIY for the user. So there is going to be a very important role for that worker who's skilled at imaging, data entry, sample preparation, slide preparation. So I think this really positions them very well for the future. And of course, all of the training has to be in local language, in Marathi as far as we are concerned, so that in some sense it really speaks to the audience. Our clinical team here worked very closely with the IIHMR team to support the diploma planning, training delivery, and assessment. Many of my colleagues are on the call today. Dr. Lavanya in particular, I want to thank for her leadership contribution to the program. This had many advantages for us, including, not the least, deepening the culture of supportive supervision that characterizes the relationship between physicians and care team. And I think by co-opting the physicians into the supervision, I think it really sort of deepens that culture of team-based care. I would say the most important area where the diploma has had an impact on us as an organization, on our health workers, is on diagnostics. Many of you know this. There are very few DMLTs available at the block headquarters and below. So previously what we do is we do point of care testing, such as an RBS or a POC A1C device, etc., and then prescribe other investigations to be done at local labs. However, as you can imagine, there was significant loss to follow up on all of these, including pretty high-risk patients. Our health workers now do the sample collection, thanks to the training, as part of their existing interaction. So same visit, you kind of get to do more, you get more value for money, and then send the same to our partner labs. And very importantly, we find that patients are more than willing to pay for this convenience of sample collection at home. And that's really something that's facilitating everything. And this is just, again, as Dr. Manjunath said so wonderfully, I think this has really sort of increased the perception of the patient that this is a skilled worker. I mean, even earlier, they would come in uniform, they would use the technology platform, etc. But I think the fact that they can now do diagnostics independently has really changed their own confidence, but also the perception of patients as to the quality and caliber of the care team that they are dealing with. One of our most important asks was formal certification aligned to the HSSC so that health workers can truly use this for professional advancement, even when they're not working with Dwara, right? So this seems like such an important and missing link, particularly as we think about the broader context of how is India going to deal with the NCD issue that many of the speakers talked about. Finally, I will just say in terms of there may be interest in terms of costs, etc. The first batch we sponsored for all 11 workers, we sponsored the cost of the diploma. Going forward, we are very keen to test out some cost recovery models so that it's also seen very much as part of the professional kind of certification journey. At rupees 35,000 per health worker for the diploma, we think this can be easily recovered over a 12 to 15 month period from salary. So I think that gives it much more scalability. But I think there are some CSR funders in the room today creating revolving funds can really expand the reach of the diploma, particularly in contexts and geographies where the scope for cost recovery may be limited. I do hope many of you after today will consider nominating your health workers for this next batch. I now invite my colleague, Madhushri Padmalkar, who's joining us from Baduj in Satara, to briefly share her experiences in Marathi with the DCH DHO program. Madhushri.
नमस्कार, मी माझी प्रथम ओळख करून देते. माझं नाव आहे मधुश्री आतिश पडमलकर. मी गोंदवले बुद्रुक येथे राहते. मी जॉब करण्याआधी बचत गटाची छोटी मोठी कामं करत होते. तशी मला नीम प्रोग्रामची माहिती मिळाली. मी गेले 4 वर्ष नीम प्रोग्राम मध्ये HS म्हणून काम करत आहे. हे काम करत असताना आम्हाला या डिप्लोमाचं ट्रेनिंग देण्यात आलं. इथं एक असा आम्हाला फायदा झाला की जॉब करत करत हा कोर्स करणं बाहेर शक्यच नाहीये. पण इथं नीम प्रोग्रामचे खरंच आभार मानते की त्यामुळे आम्हाला हा डिप्लोमा कोर्स करण्यास संधी मिळाली. या डिप्लोमा कोर्समध्ये आम्ही नवीन नवीन आजारविषयक माहिती, प्राथमिक आरोग्य उपचार पद्धती, नवीन आजारविषयक माहिती, तसेच ॲनिमिया असणाऱ्या लोकांसाठी काय माहिती त्याच्याविषयी माहिती मिळाली. ब्लड सॅम्पल कलेक्ट करू शकलो, इंजेक्शन करायला शिकलो. स्वतःला सुईची भीती वाटणारी मी आता यशस्वीरित्या दुसऱ्यांचं ब्लड सॅम्पल कलेक्ट करू शकते. यामध्ये मेन आमचा म्हणजे आरोग्यविषयक माहिती तर आम्हाला भरपूर मिळाली. त्यामध्ये आम्हाला मानसिक आरोग्याचीही माहिती मिळाली. हा रोल आमच्यासाठी खूप नवीन होता की इव्हन लाईफमध्ये जगत असताना आम्ही कधीच मानसिक आरोग्य प्रत्येकाचं कसं असू शकतं, ह्या धावपळीच्या युगात आपण कसं जगतोय किंवा प्रत्येक व्यक्ती कसा राहत असेल ह्याचं काही ज्ञान नव्हतं. पण या डिप्लोमा कोर्समध्ये त्याची आम्हाला पूर्ण माहिती मिळाली. त्यामुळे माझ्या पेशंटसाठी तरी मी ह्या ताणतणाव मुक्तीसाठी त्यांना मी आता मदत करू शकते. तसेच मेन फोकस फ्लिबोटॉमी. आता पेशंटला जाऊन माझ्या लॅब पर्यंत जाणं येणं, त्यांना ब्लड सॅम्पल देणं, हे आता मी जसे की रोजच्या दैनंदिन ह्याच्यात मी नीम प्रोग्राम मध्ये त्यांचं डेली रुटीन चेकअप तर करतेच, BP शुगर या फोकस करून करते. पण यामध्ये आता जाऊन मी त्यांचा सॅम्पल कलेक्ट करून लॅबच्या मार्गदर्शनाखाली त्यांचे सॅम्पल कलेक्ट करण्याची मला संधी मिळते आणि मी ते यशस्वीरित्या करूही शकते. तसेच आताच्या सध्या कसं झालं की मी रुटीन प्रमाणे काम करणारी लेडीज BP शुगर चेक करते, पण पेशंटला आता माझ्यावर खूप ट्रस्ट वाटतोय की ह्या मॅडम आधी येत होत्या, रुटीन प्रमाणे चेकअप करत होतात, आता ह्या सॅम्पल कलेक्ट करू शकतात. म्हणजे ते नाविन्यानं माझ्याकडे बघतात, त्यांचा बघण्याचा माझ्याकडचा दृष्टिकोन बदललाय. ते फुल्ली ट्रस्ट आहेत माझ्यावर. त्यामुळे माझा आत्मविश्वास वाढलेला आहे. आणि यात कसं झालं की ह्या 4 वर्षाच्या जर्नीमध्ये माझं कसं होतं की मी एक हाऊसवाईफ ना, माझी कुठेही ओळख, 4 लोक मला फक्त ओळखत होते. आता नीम प्रोग्राममुळं लोकांचा बघण्याचा दृष्टिकोन बदलून ते माझ्याकडे आदर आणि सन्मानाने बघत आहेत. ह्या मॅडम ओळख वाढली, मला ह्याची प्रचिती मिळाली, मला ह्याचा खूप आनंद वाटतोय. थँक्यू.
Yeah. Thank you, Dr. Bindu, and thank you, Sachin. I think this was really interesting because hearing from the people who have been trained really adds value to the things. I think coming to the last segment, I guess I will just briefly breeze through what are our plans for next 3 years, what is the partnership models that we are looking at, and overall how we are looking at adding more partners who can contribute more to the program and kind of substantially improve the overall frontline workers training, skilling, and the primary healthcare delivery. So I think, yeah, it just starts. So I think one of the, just give me 1 second. Yeah, I think one of the key elements that we had already emphasized is the phlebotomy skill. What we have done is that understanding that this is the group of people who would always be working under the observation of a trained healthcare provider like a nurse or doctor. We try to kind of build a comprehensive aspect, what we call it as a 37 credits, which translates to 370 hours of learning. And we try to map it with the job roles that the Health Sector Skilling Council and NSTC have mapped with their program. So what you would also see there are two interesting things. Though we have mentioned eligibility class 10 and somewhere we have mentioned class 12, there are two aspects. We are looking at three types of engagement. One is that if there is an health worker with a civil society, they can be class 10 plus or a class 12 plus. This diploma would be one that would kind of give them the credentialing required to be more of a trained healthcare worker. But if someone is freshly planning to join as a frontline healthcare worker, we consider that with today's market and today's requirement, a class 12th is a much better for a youth because that also gives them to build on future courses. So that's where if someone is working already, has been kind of working for a long time, the class 10 eligibility comes in. But if someone is very fresh and wants to shift to the healthcare as a kind of career with the frontline worker being the first step, the class 12th was what we have added. We also have a rural micro entrepreneurship options where irrespective of the learnings, they can get the diploma with the help of civil societies that are working across the areas who are partnering with us, and then they can liaison with the local labs, with the local doctors who can they can do the home health or outreach for them. So there are three models which we have been looking around, and we have mapped approximately 7 job roles like GDA or health assistant or MLT, wherein they can fit around. So even the hospitals, if they are looking to expand into rural areas, this program gives them a trained and certified professional. If there is some clinic who wants to extend their clinical outreach to the community, there is a program. The same program has same skilled people who can work. So in rural areas where there is need of people who are trained, I think this program really fits into that requirement. So these are all. The ODT technician basically is not completely like for the high-end OTs, but if the small OTs, like there is a suturing done. So maybe you have someone who stand besides the doctor, give them maybe a sterile needle, a sterile glow. So that kind of smaller roles is what this is. Even for EMT, giving basic CPR is covered under the model. So that's where I think we have tried to see what a rural India would look like as an assistant. Also, the home health is one area where we have been kind of interestingly working around, considering it's both focus on for urban and rural India. So that's again some part like the basic management, counseling, blood drawings or sample collection, all those things come into play. So that's the thing, the overall skill package that we are trying to build into the 11 months. But again, the 11 months translate to something on 370 hours based on how. So if so, that's why I think we are trying to also take support from AI. So we have been working around a clinical support system, which technically will guide the frontline workers in the field to when to refer, when to take a decision, or when kind of to go step back and maybe ask for some more knowledge to learn. So that's, I think, a new thing that we're pitching, and this would be forever available for the frontline healthcare worker. Even after completing the program, the access would not be revoked. It's there for learning because that's the learning material that they have, and also the material to support it. So that's the way IHMR wants to continue supporting them. Even after the diploma is completed, or even after they are working in the field. So that way, there is always something to bank on, and there is some tool or AI based tool which would help the frontline workers to guide them in the crisis or whenever they feel they require some support. And the model is pretty much kind of tested internally with our testing showing around 88%, 89% of routing accuracy. We have tested on 130 clinical vignettes, and 11 workforce is what we're trying to now validate it, that it's a future plan. And this is the three approaches that how we expect and we can work with the partners. One is obviously what Dwara's efforts have been like, sponsoring the training of existing healthcare workforce. That's the plan, with 30,000 rupees per participant for certification, which includes IHMR training them, certifying, along with access to the all the curriculum, LMS, and this thing. While the civil society or the CSOs are working, they support in terms of nominating a doctor who will oversee this, or any kind of senior nurse who can supervise this thing, support in Viva and field oversight. There's another option which I think we have been kind of talking with some of the partners, where the fresh graduates who are 12 pass would be kind of trained to the program. Same structure, but these are the fresher people who are newly entering the health system rather than the early. IHMR will deliver training, certification, and entire curriculum with the LMS and AI. While the CSO will kind of look at in terms of how to coordinate the field and maybe support the placements for them. That's for the livelihoods aspect. And third is when, if there are some organizations who are already doing this training and they feel that the training is sufficient, but they need to certify the frontline workers. And that's where I think IHMR will work with those organizations to see how to align this thing with the IHMR structure, like 370 hours, 37 credits, along with access to the LMS and kind of support in the certification. And that's where we are also looking